Hello, welcome to my introduction to rheumatology talks. I've been a rheumatologist in practice for over 30 years, and during that time I've had the opportunity to give lectures to sophomore medical students in their Introduction to Medicine course on rheumatology. That's the basis for the lectures that I'm going to give. I've tried to avoid using jargon as much as possible when I made these, but occasionally I may use a word that I don't explain well. If I do, just feel free to look it up. The word could be typed into Google and you can generally find the meaning of it. The lectures will be posted in the order in which I made them, although many times they'll stand by themselves, so one doesn't necessarily need to watch all of them, and certainly you can pick and choose which talks might be of interest to you. I hope this is helpful to you and informative, and I hope that you learn something. Thank you for listening to my talks.
Good morning. Today we are going to talk about rheumatoid arthritis. Specifically, I'll talk about what it is, why we think people get it, how it affects the body, what we see clinically, and then how we make the diagnosis. Now basically, rheumatoid arthritis is an inflammatory arthritis that involves many joints. It's inflammatory, which is different than osteoarthritis, which is sort of wear and tear. And it involves many joints, so it's polyarticular. And we think it's due to the immune system attacking the body, what we call autoimmune. So it's an autoimmune inflammatory arthritis. We don't know why people get it for sure, but we believe that it's due to a genetically predisposed person or genetically predisposed host and something in the environment kicking it off. There's data to suggest that it is genetically predisposed. People with rheumatoid arthritis have a higher amount of the transplantation antigen called HLA-DRB1. The transplantation antigens obviously are important in identifying whether people accept organs for transplant, but they're basically important in the way the immune system signals itself and functions. We also find that there's genetic changes in the STAT4 haplotypes and the TRAF1 locus. These are genetic markers for certain chemicals that the body uses for the immune system to function. There is data to suggest certain things in the environment set it off. People that smoke have a higher incidence of rheumatoid arthritis than people that don't smoke, and we'll talk about why that might cause rheumatoid arthritis later. People that have extra weight, obesity, have an increased risk of rheumatoid arthritis. If there's chronic inflammation in the mucosal linings or in the lung, those people can have a higher incidence or increased risk of rheumatoid arthritis. People that have different bacteria in the mucosa or the gut or the lung airways, different what we call biome, can have an increased risk of rheumatoid arthritis. Occupational exposures such as silica can increase the risk of rheumatoid arthritis. Interestingly, workers at the World Trade Center after the 9/11 suffered a greater rate of rheumatoid arthritis. And again, I think this shows there's something in the environment that kicked it off. Then lastly, stress is thought to be a potential insider of rheumatoid arthritis. Now, to understand what's going on in the body, we need to talk about the alphabet soup of immunology. Basically, the T4, the CD4 lymphocyte, T lymphocyte is felt to be the central orchestrator of the immune response in the synovium in patients with rheumatoid arthritis. Now, how that works is the macrophage is the cell that sort of goes around in the body. It gobbles up sort of the junk around viruses, bacteria, just sort of junk laying around. And what it does is it gobbles that stuff up and then presents the antigen, the proteins from that stuff, to the T cell. Now, it presents it in conjunction with a major histocompatibility antigen, class 2. The MHCs are actually the transplantation antigens, the HLA-D antigens that we talked about. It's presented to the T cell, and if the T cell recognizes the protein, then it will send a signal back to the macrophage with what we call cytokines. Cytokines are cellular messengers, IL-2. This will then stimulate the macrophage to produce its own cytokines, including IL-1 and TNF-alpha, and it just sort of revs up the response. This is what we just looked at. So this is just the antigen presentation of the macrophage to the T cell and how it gets it gets it activated to start an immune response. The T lymphocyte then will start dividing, what we call clonal expansion. So the T lymphocytes that recognize that antigen will start expanding. They'll start making more and more of them, and that'll start throwing out a bunch of cytokines, including interferon N gamma, interleukin 6, interleukin 8, interleukin 2, and TNF. And this is just sort of stimulate the immune system to go to work. Now, this is a nice description of what's going on in the synovium in people with rheumatoid arthritis. Again, you have the central CD4 T cell that's sort of orchestrating the whole thing. It's sending interferon gamma to the macrophage, which is producing TNF alpha and IL-1 and 6. The IL-1, these cytokines or cellular messengers will stimulate the chondrocytes. The chondrocytes are the cells in the cartilage, the osteoclasts, which are the cells in the bone, and the fibroblasts, which are important in making these things up, to produce what we call metalloproteinases and other molecules. The metalloproteinases can actually cause breakdown of the tissue of the bone and cartilage. And this calls in or brings in the polymorphonuclear cells. The polymorphonuclear cells are the white blood cells that we see in pus, and we see a lot of these in the synovial fluid of patients with rheumatoid. We don't see it in the synovium, actually, which can lead to damage of the bone and cartilage. The T cell also stimulates the B cell. The T cell is part of what we call the cellular immunity. The B cell is what we call the humoral immunity, and this makes antibodies such as rheumatoid factors and other things. The T cell actually can downregulate the system somewhat also by IL-4 and IL-10, and that can then stimulate the T helper cells. So in the synovium, we have sort of this inflammatory process going on, orchestrated by the T cell after the presentation of the antigen by the macrophage, which can recruit a lot of the rest of the immune system, but can also stimulate the polymorphonuclear cells and cause a lot of damage. So again, if you recall, this is the normal joint. You have the synovium here that produces a fluid that bathes and feeds the cartilage. Remember, the cartilage has no blood supply, so it has to be fed by synovial fluid. Normally the synovium is 1 cell thick, but in rheumatoid arthritis there's then this setup of a large number of T lymphocytes and mononuclear cells. That's the immune response. And so you can see this is a lot different. This is 1 cell thick. This is very thick. You also get a lot of blood vessel growth, what we call neovascularization. And this is an immune tissue, almost like a lymph node growing in here. So early on in the course of rheumatoid disease, we have sort of this synovial proliferation and thickening. As the disease progresses, blood vessels grow into the synovium so that it actually is well established. We call this neovascularization. This then continues to progress till we got a large amount of synovium we call pannus, which is eroding into the bone and cartilage and causing damage. And there's a lot of polymorphonuclear cells trafficking into the synovial space, or not the synovial space, but actually the synovial fluid. So this is just what we see histologically, or when we look at it under a microscope, this again is the cartilage. And again, it's you'll see the chondrocytes, but with no blood supply to it. This is the bone, and then this is the bone marrow. And you see the synovium sort of eating into the cartilage and eating into the bone. And then this is just a surgical specimen. This patient was having what's called a synovectomy. In other words, a surgeon was going in and cleaning out the synovium, and you can see the large proliferative synovium right here. So what do we see clinically when we encounter rheumatoid arthritis? Now, typically the patients will present with a history of joint pain and swelling, usually lasting more than just a day or two, but not any more than a few weeks to a few months. The onset can be palindromic. In other words, it can involve just a few, it can come and then go away. It can be polyarticular, involve just a few joints. So initially it may not even look like rheumatoid. It may come on with just a few joints that come and go. However, ultimately, when we follow the patients, it can progress to full-blown polyarticular inflammatory arthritis. Now, it doesn't have to. Perhaps a third of patients with palindromic onset never have another palindrome, or they may have palindromes that come and go. Polyarticular, though, if it is rheumatoid, it will progress to a more polyarticular presentation. There can be constitutional symptoms. Again, this is an all-over body disease. So the most common constitutional symptom is morning stiffness that can last hours at a time, but they'll report other things such as fatigue or possibly weight loss or possibly fevers. There can be a change of loss of function. And again, going back to our initial lecture where we talked about the evaluation of the rheumatoid patient, it's important to ask, are they still working? Can they work? If they're working, what do they do when they go home? Are they still doing their avocations, their hobbies and sports and stuff like that? Epidemiologically, we tend to see that it in women more often than men, and about a ratio of 2 to 1. Previous data have suggested 3 to 1. It tends to affect people during the prime of their life, ages 30 to 55, the peak productive years. And this is what makes it such a devastating disease. This is probably why it's got the name crippling arthritis, because you imagine if you had a polyarthritis that affects you at your peak productive years, you can't work, you're crippled. Generally, the incidence in the population is about 30 per 100,000 per year. And the prevalence in the population, our population, about 1% in Caucasians. The only other comparative I have is rural Africans, about 0.1%. So given that this is a population that may be different genetically and may have a different environmental risk factors, it's hard to say what that means. Now, what we see clinically is that there's swelling in the joints. And this swelling is a soft, boggy swelling. If one pushes or squeezes on the joint, one feels that it's sort of soft and smushy. It typically involves the PIPs, or proximal interphalangeal joints, and metacarpal interphalangeal joints of the hands. It tends to be symmetric, and I think that's what we're trying to show here, that it's in the MCPs on both sides. There's some edema on the dorsum of the hand here. Typical joints that are involved include the neck, shoulders, elbows, wrist. We talked about the fingers, and I have some more pictures of that. The hips, which isn't shown on this slide, knees, ankles, and then the metatarsal phalangeal joints to the feet. It never, ever, ever involves the low back, and that's important to note. I've seen patients that were referred to me for low back pain. They were worked up by other physicians. They ordered a rheumatoid factor. It was positive, and they were thus sent for rheumatoid arthritis, but never affects the low back. The hands typically can affect the wrists. This is a bone scan, and basically it's radionucleotide tracer. It tends to go to areas of increased metabolic activity, but it tends to affect the wrists, metacarpal phalangeal joints, or MCPs, and the proximal interphalangeal joints, or PIPs. It does not affect the DIPs. Now, this is an example of the deformity that can occur with rheumatoid, and this is what we want to avoid. And what you're seeing here is that there's ulnar deviation. The fingers are deviating towards the ulnar side of the hand, probably due to wrist involvement with the wrist actually deviates radially, and then the force vector of the extensors of the fingers causes the fingers to go to the side ulnarly. Um, ulnar deviation, there's probably some subluxation. The bone slipped off of the metacarpal phalangeal joint. There are nodules, rheumatoid nodules. This exam shows what we call swan neck deformities, and again, that's the tendons that function to flex the fingers that flip to the other side of the joint cause them to extend with flexion, extension at the proximal interphalangeal joint with flexion at the DIP, or what we call a boutonniere deformity, like putting on a button, and that's fixed, though that won't change. Rheumatoid arthritis can involve the neck, and what we're looking at here, this is a cervical x-ray. This is the C1, or the first cervical vertebrae, or the atlas. This is C2, or the axial vertebrae. Now, the front of C2 has a bone that sort of sticks up, and actually the bone is sort of usually right up next to the anterior arch of C1. This is called the odontoid, and what we see in this rheumatoid is there's instability. There's a separation between the odontoid and the anterior arch of C1. This can be dangerous because this can actually pinch the spinal cord when one flexes or extends the neck, and can cause paralysis. It's important for the anesthesiologist to know about this, because when people are put to sleep for surgery, they are frequently intubated. In other words, a tube is put down the throat into the lungs. To do that, the anesthesiologist will typically hyperextend the neck, and so they need to know about this so they can do things to avoid that. You wouldn't want to send a patient with rheumatoid arthritis to surgery and have them come back paralyzed. So it can involve the neck. There are what we call extra-articular manifestations of rheumatoid arthritis, and these are things that occur outside of the joint. This is an example of a rheumatoid nodule. These are little areas of inflammation, and of themselves they are not a problem, although they can sort of get in the way and rub against things. We did see a picture of those on the hands. They are an indicator of poor prognosis. There can be inflammation in the blood vessels, which we call vasculitis. What you see in this picture, what we call splinter hemorrhages, and these are due to little areas of skin infarction. Infarction means cell death, sort of like myocardial infarction means heart attack that causes death of the heart muscle. This is skin infarction here. And sometimes we can even get a very severe fingertip infarction, which is shown here. This tissue is dead. It will eventually slough or fall off. They can have several types of lung involvement. They can have involvement of the lining of the lung, which we would call pleurisy. This area here is a pleural effusion. That means there's fluid between the lining of the lung and the chest wall. They can have scarring of the lung, which we call interstitial fibrosis. This can be a dangerous and life-shortening complication of rheumatoid arthritis. We are getting therapies currently, or at least therapies are being tried currently. That still is a very dangerous thing that can occur. Pulmonary nodules can develop. Now, these tend to happen more often in industrial exposures, like exposure to silica or coal or asbestos. This can occur very suddenly. Given the fact that people that smoke tend to get rheumatoid more often than people that don't smoke, these do need to be worked up to determine if they're a cancer and probably need to be biopsied. There's something called Kaplan syndrome, which is where people have industrial exposure to things like asbestos or silica or coal and develop these. There's a type of pneumonia called bronchiolitis obliterans with organizing pneumonia or a BOOP. And then lastly, with respect to the lungs, and there's probably other things associated, but methotrexate, which is one of the treatments that we use for rheumatoid arthritis, can be involved with an inflammatory uh, response in the lungs like pneumonitis or like pneumonia. There can be heart involvement. Sometimes people can have inflammation of the lining of the heart, which we call pericarditis. Sometimes they can have inflammation of the muscle of the heart, which we call myocarditis. And there seems to be an excess amount of cardiovascular disease in people with rheumatoid arthritis. It could be because the atheroma or the sort of the thing that's occurs in the blood vessel, obstructing the blood vessel is an inflammatory process, but we do see an increased cardiovascular risk. In this slide, this is normal women, and this is their survival rate. If you take time zero and look at how many survive as you move forward, this is the normal population of women, this is the normal population of men. And then if you look at the population of women that have rheumatoid arthritis, you see that they die at a greater rate. And likewise, if you look at the population of men that have rheumatoid arthritis, you see that they die at a higher rate. So it looks, rheumatoid arthritis isn't necessarily a benign disease. I mean, people can die from rheumatoid arthritis. There can be blood involvement in rheumatoid disease. There's something called anemia of chronic disease. Now, basically, this is an anemia that occurs when there's sickness or a lot of inflammation going on in the body, and basically the bone marrow is just not as effective at making red blood cells. There's a condition called Felty syndrome which could occur. Now, we don't see this as often in the current age with the more advanced therapies that we have, but basically this is the triad of seropositive rheumatoid arthritis. Seropositive means they have a rheumatoid factor with low white count, which is we call neutropenia, and splenomegaly. They also can have skin changes, ulceration in the front of the legs, etc. Large granular lymphocyte syndrome is a type of leukemia, and these patients have a clonal expansion, clonal meaning that all the cells have the same genetics like we see in a cancer, clonal expansion of the large granular lymphocytes. Approximately, I think about a third of the patients that have the large granular lymphocyte syndrome have rheumatoid arthritis. Now, patients with rheumatoid, only maybe 3 to 4% can have this large granular lymphocyte syndrome, but we do see this associated with rheumatoid, especially if they have it. There is an increased incidence of hematologic cancers or hematologic malignancies, or those are blood cancers, things like lymphoma and leukemia in people with rheumatoid. This is a problem when we go to look at our medicines because statistics would suggest that some of our medicines may actually increase the risk of hematologic malignancies, but when we encounter a patient with these, we never know whether it's due to the disease or due to the treatment. Eye involvement can occur. Probably the most common is Sjogren's syndrome, which is a condition where they have dryness of the eyes and dryness of the mouth and other things. They can have just inflammation of the little outer membrane called episcleritis, or they can have it of the outer tough coat of the eye called the sclera, which we call scleritis. Now this can progress to the point where we actually get erosion all the way to the deep part of the eye, which we call a corneal melt. And one can imagine if this occurs, this could affect or cause a loss of vision. So it's something that needs to be treated very aggressively. They can have inflammation of the middle coat of the eye, which we call uveitis. And actually, there's clues of this in this picture. You can see that there's some precipitates in the outer chamber of the eye there. Lastly, some of our treatments can cause damage to the eye. The corticosteroids such as prednisone can cause glaucoma and cataracts, and then hydroxychloroquine can be associated with retinal changes. Now, what are the special labs that we look at? The first one I'm going to talk about is the measures of inflammation of the acute phase reactants, and I want to talk about the SED rate, the erythrocyte sedimentation rate. Basically, what happens if one sets blood on a counter, the blood will separate and the red cells will sediment out or drop, and the clear sera will remain on top. Sort of like you see if you take pond mud and you stick it on a shelf in a jar, you'll see the dirt sort of settle at the bottom and there'll be sort of a clear coat of water on top. So the way we do the erythrocyte sedimentation rate, especially by the Westergren method, is we put blood in a tube. It's 200 we put 200 millimeters of blood, so we measure it 200 millimeters, and we let it settle for an hour. And how far it settles is what we call the SED rate. Normally it settles no more than 20 millimeters per hour or less. However, if there's a lot of inflammation, it can settle much quicker. And this is because the way the blood sort of sediments is the blood cells sort of stack up on each other, what we call rouleau. And in inflammation, there's more attraction of the cells, more electrostatic attraction of the cells, so they rouleau or stack up quicker. And so that's what you see here. This is a very high sedimentation rate. The fluid is stacked up very quick. Now there's a limit to how tightly the cells can pack. This is the volume of the red cells in the fluid, or what we call the hematocrit. In men, the normal hematocrit is about 45%. So in a 200 millimeter tube, the hematocrit would be about 90 millimeters, right? So the maximum sedimentation rate one could have would be 110 millimeters. Now, as we mentioned, there is anemia of chronic disease, so our patient's hemoglobin is usually much lower. So in a men, you might think the hematocrit might be around 30%, which would be a max SED rate of about 140. And that's typically what we see in rheumatoid. The SED rates are usually much higher than 20, usually in the order of 50 up to 140. So this is the type of tube that's used to measure the sedimentation rate. Again, the blood is put in the tube and allowed to set for an hour. Other measures of inflammation include the C-reactive protein, which we watch. The hemoglobin can be a measure of inflammation also. As we mentioned, it does drop in inflammation. Now, the rheumatoid factor is very useful in evaluating and diagnosing rheumatoid arthritis, although I will state it's not diagnostic. In other words, the presence of a rheumatoid factor doesn't mean the patient has rheumatoid arthritis. And the fact that a patient does not have a rheumatoid factor does not rule out rheumatoid arthritis, and we'll look at that in a minute. But basically what the rheumatoid factor by what we call the Rose-Waller method is antibodies to the constant portion of the IgG, which is the immunoglobulin or antibody. This is what an antibody or immunoglobulin looks like. You have the constant portion right here, which can sort of act to fix things like complement, which sort of destroys cells. And then you have the variable region up here. This is the part that recognizes the foreign antigen and starts the whole process. Well, what rheumatoid is that there are actually antibodies that attach to this constant portion. 75 to 80% of patients have these during the course of the disease, although I will state that that's during the course. Early on, we'll see that may be less than that. And again, they're more useful in prognosis. Now, the cyclic citrullinated peptide was described just recently in the last few years, and basically what was found is that there were antibodies against an amino acid sequence called citrulline, which was sort of novel, that shared sensitivities and specificities with the rheumatoid factor. Now, citrulline, what we find is that people that smoke actually tend to convert arginine to citrulline, or at least their macrophages tend to produce an enzyme that converts arginine to citrulline, and thus this may create a neoantigen or a novel protein sequence that the body doesn't recognize, so considers it a foreign sequence and it initiates an immune response. So this might actually be a clue, at least one clue to what starts or what causes rheumatoid arthritis. But what we find with the citrulline antibodies, I'm going to call them CCP just to make it easier. What we find with the CCP antibodies is they're probably not any more sensitive to rheumatoid and early disease, only about 50% sensitive for CCP, only about 50% sensitive to this is the rheumatoid factor, the IgM rheumatoid factor ELISA, only about 50% sensitive. What sensitivity means is if you take people that have the disease and then you take the number of people that have the test, if that's the number of people that have the test over the number of the people that have the disease, is the sensitivity. Now, ideally, the sensitivity should be about 100%. I mean, you want to make a test really helpful, every person that has the disease should have the test, but it doesn't happen that way. Now, specificity is 1 minus the number of people that have the test that don't have the disease. Okay, so to say a test is 96% specific, that means 4% of people that don't have the disease have a positive test. So in a perfect world, you'd have a test that's 100% sensitive and 100% specific. In other words, the test is always positive when you have the disease and never positive or never false positive when you don't have the disease. But the fact is we don't see that. Now, what we find here is in using these two tests together is that if we combine them, if we have either a CCP or a rheumatoid factor, that increases our sensitivity a little bit, up to 63%. But what's really interesting is if we have a patient that has a CCP and a rheumatoid factor, the risk of false positivity is getting very low, and so there's a very high probability that they do have the disease, rheumatoid disease. So that's why we check them both, and when we see them both positive, that tells us we do have the disease, or at least it doesn't tell us, but it pushes us strongly in that direction to make the diagnosis. But it's also a useful prognosticator because people that have the rheumatoid factors and CCPs tend to have worse disease. Other tests that we do include X-ray. And this is just an example of what we see on X-ray. Early in the course of the disease, there's really not a lot to see. If you look at these joints, the joint space is well preserved. Now you do see some haziness about the joint. That is because the boggy or thickened synovium, but we can't really see synovium on X-ray, but the joint space is well preserved. This is a series that shows the progression as rheumatoid is followed. As you can see it early on, it looks fairly normal. There may be a little bit of periarticular osteopenia, and what that means is the bone looks thinner around this area, which we call osteopenia, periarticular because it's around the joint. As we progress, we can see erosions develop. In other words, it looks like something's eating this bone, and very far into the course of the disease, we see a lot of erosion, a big erosion, and we see that a lot of joint space has been lost. It's almost bone against bone here. Now this is very advanced disease. This is what we don't want to see. But again, in the wrist you have a lot of involvement. Indeed, this is underpenetrated, so you can't really see the wrist well. Underpenetrated means there just isn't enough X-ray to see the definition. This may also be due to the fact that this is probably a copy of a copy, but it's underpenetrated. But what you often will see is that there's a lot of erosion of the bones of the wrist. You may even lose a whole row of bones of the wrist, and this causes, again, the wrist to deviate towards the radial side of the hand. When that happens, the tendons that sort of straighten the fingers, their vector is right along here, and so that will cause the fingers then to deviate towards the ulnar side or ulnar deviation. Other things you see in here is as you move, the joint space isn't too bad here, but as you move along here, you can see the joint space is markedly lost. There is periarticular osteopenia. In other words, there's thinning around the bone, and there's erosion of the bone, and there may even be subluxation. The finger may have fell off of the bone there. In other words, subluxed. Now the next question, or the question is, how do we make the diagnosis of rheumatoid arthritis? I think that it's helpful to look at the classification criteria in order to make the diagnosis. Now, basically what classification criteria are there a set of criteria that were set up in order to make everybody agree that people in clinical studies, in experimental studies with the disease, all have the disease. Okay, so they're important in research, but I think they're also important for the clinician or they're helpful to the clinician in the office. This is the old 1987 criteria, and in this criteria, one needed at least 4 of these positive that had been going on for at least 6 weeks. So things that we looked at is morning stiffness lasting more than an hour, arthritis of several joints, arthritis of the hand joints, a symmetric arthritis, rheumatoid nodules, rheumatoid factor, and X-ray changes. So one could make the diagnosis if they had stiffness lasting several hours. The hand joints alone, if you had the hands and you had mostly MCPs and PIPs involved, you'd have 3 or more joints, arthritis of the hand joints, and a symmetric arthritis, and you can make the diagnosis of rheumatoid. These other factors, one of the challenges with rheumatoid nodules and X-ray changes in particular is they occur late. We're looking at patients that had at least 6 weeks of disease, and so by definition this would cause one to make the diagnosis later. Now, in the last few years or so, and I say few, maybe the last 20 years or so, we've come to appreciate that we want to treat the disease much more aggressive, much earlier. So in 2010, they came up with a different set of criteria to help allow earlier classification of the disease, so we could put people in studies with the disease earlier and try to see if we can find treatments that significantly change the outcomes. So these are the 2010 criteria by the American College of Rheumatology in conjunction with the European League Against Rheumatism. This is sort of a European analog to the American College of Rheumatology, or EULAR, and they came up with this set of criteria. Now, this is different than the previous criteria in that different things were scored rather than just counted 1, 2, 3, 4. Time is not this part of this criteria other than just one factor in the criteria. And so you could see that if you had a patient that had multiple small joints, especially small joints, and maybe a high titer rheumatoid factor ACP, they could be placed in the studies very early. If they had 10 joints involved and with an elevated acute phase reactance, they could be placed in studies very early. So in using this criteria, one can see that patients could be put into studies earlier. We can make the classification sooner, and we can initiate treatment sooner and maybe change the outcome. So I think these are helpful to look at. So we talked about things we look for and how we look at patients in order to make the diagnosis, and we talked about sort of using the classification criteria as guidelines to make the diagnosis. One thing that's very important in medicine is when we encounter something that we think is going on, it's important for us to think about things that might look like it, what we call the differential diagnosis. What I oftentimes tell students is, if you don't think about it, you won't make the diagnosis. So the question is, what other kinds of things do we think about when we see an inflammatory polyarthritis that looks like rheumatoid arthritis? Number one, systemic lupus has an inflammatory arthritis that looks very much like rheumatoid, and we'll see that when we get into that section. Other systemic autoimmune diseases, and I state this, my last 2 patients with vasculitis actually presented with an inflammatory polyarthritis. The seronegative spondyloarthropathies. Things like ankylosing spondylitis and what we used to call Reiter's syndrome tend to present with a post-articular onset, in other words, just a few joints. But we mentioned sometimes rheumatoid will present with a few joints. So you need to think about these when you see that. One of the seronegative spondyloarthropathies called psoriatic arthritis, in other words, arthritis associated with psoriasis, can look very much like rheumatoid. Crystal-induced arthritis, things like gout. Gout doesn't tend so much, that tends to be post-articular and acute onset, but something called pseudogout or calcium pyrophosphate deposition disease can have wrist involvement and knee involvement, and sometimes the inflammation can be more long-lasting or indolent and can look just like rheumatoid arthritis. Infectious arthritis, gonorrhea, again, can present with a sort of a polyarticular migratory arthritis that can look like rheumatoid. Now, the non-gonococcal infectious arthritis typically is just monoarticular. If it's polyarticular, can have a very bad outcome. It's a very bad prognosticator. I listed or mentioned polymyalgia rheumatica here. I don't have any other talks about it, but I just want to mention it. Polymyalgia rheumatica is a condition. It tends to occur in older adults, and they have sort of the sudden onset of pain in the shoulder and stiffness in the shoulders and hips. And by sudden, I mean it can occur overnight. And a lot of times people can tell you with hours when there was an onset. Typically occurs in older people, older than 50, generally in their 70s or 80s. The sedative rate or the erythrocyte sedimentation rate can be very high, and they're exquisitely sensitive to treatment with corticosteroids. And what I mean by that is as little as 5 to 10 milligrams of prednisone per day can take it away, and really quickly. It's almost magical. And indeed, these patients, I always say they're good for 2 or 3 more, or maybe up to 10 more consults, because you see somebody with polymyalgia rheumatica and you treat them and they get better and they go tell all their friends, and their friends come streaming in hoping you can do the same for them. The thing about polymyalgia rheumatica that's remarkable to me is the change in function. This is where function is so key. Typically, these people are functioning normally, they're active, they're usually involved in things, and then all of a sudden they can't do anything. I sometimes describe it as they go to bed a young man and wake up an old man, or go to bed an young woman and wake up an old woman. The other thing is when I'm evaluating, I'm looking for corners. They're going in this direction, all of a sudden they turn the corner and go that way. That's how I evaluate a lot of disease, but you especially see it in polymyalgia rheumatica. Other conditions we see, sarcoidosis can have an inflammatory arthritis. Sarcoidosis is a granulomatous disease where they have granuloma in the lungs and some of the other tissue, but that can be associated with the polyarthritis. Patients that have cancers can sometimes have an inflammatory arthritis as their presentation, especially a lot of the hematologic malignancies. And one can see how this can be an issue because people with rheumatoid can have hematologic malignancies. So you know which cause which. Multicytric reticulohistiocytosis can have a very deforming arthritis and skin changes. And of course, there's other things. So today I spent some time talking about rheumatoid arthritis, what it is, how I diagnose it. The next set of talks, the next talk is going to be about how I treat it. And I'm going to spend a little bit of time because I think that's probably something a lot of people have an interest in. Thank you for listening to me.
So that concludes this talk. I thank you very much, and there'll be further to follow.